All right, so we are going to talk about a concept called managing care. And here we're really going to look at some things like what med-surg nursing really means, and then go over the QSEN competencies. So what actually is medical surgical nursing? Well, first of all, it's considered to be the basis for all other types and specialties of nursing. We call it the foundation for nursing care. Med-surg nursing is practiced in a lot of different settings, including acute care facilities, long-term care facilities, outpatient facilities. Really what we're doing is we're caring for the adult patient, so those individuals who are 18 years or older. Let's see. So the focus of the med-surg nurse is on the management of the illness of that adult patient. Med-surg nursing is actually a specialty in and of itself. It's not only the foundation of all other types of specialties, but it is its own specialty. It's very broad in nature. I myself am a medical surgical certified nurse. And really what that means is that I have shown evidence of being a quote-unquote expert medical surgical nurse. I have a good understanding of the med-surg process, of the patient's plan of care, of outcomes, of expected actions, of trajectory of care, and I'm able to put that into practice to provide quality care with good outcomes for patients. So that's kind of what it means to be a certified med-surg nurse. Now you can become certified in a variety of different specialties, case management, oncology, critical care, progressive care, ortho-neuro. I mean, there's so many different specific types of nursing out there. You can become board certified in any of those specialty types of nursing. And it would be the same kind of thing. It would be telling people that you are an expert in that particular specialty of nursing. We take on a lot of different roles. I know traditionally when people think of a nurse, we think of that caregiver role, but our role as nurses is really much more broad than that. We coordinate the care for our patients. We are the person that is right there at the forefront, at the bedside with the individual, working together and spending the most time with that patient or client, getting to know their needs and their health and that kind of thing. So we are really good at being able to advocate for that person, being able to pull in other members of the team that can help improve the outcomes for that person, making sure that the patient has the education that they need to overcome whatever barrier it is that they're facing that will lead them ultimately to their idea of health. Nurses are leaders. We go out there and we drive change, and we can drive policy, and we can drive, a lot of different areas of just the way healthcare is delivered and outcomes are met. I think the most surprising thing for me when I was a new nurse was how much nurses actually educate. And the more I've worked, not only as a bedside nurse, but also as a nurse educator, the more I have come to appreciate learning how to be an educator, a bedside educator, while you're still a student. And the reason I say that is, as students, oftentimes I hear people say, oh, I just don't know. I know so little, and, I just don't know all of this stuff to be able to educate a person on this. But truly, the best way for you as a new nurse to understand whatever concept it is you're educating it about, whether it's a disease process or a medication or a surgical procedure, is to educate that patient. It helps to kind of, I guess, solidify in your mind. Speaking it out, it requires, because you want to feel competent, it requires you to do a little bit of research into the concept or to the topic. So yeah, I think that was probably the most surprising thing that I found as a nurse, is how much education that we actually do at the bedside. Advocating for that patient and family is really key, especially in how fast-paced healthcare really is. There are a lot of things coming and going. Just like nurses can have a variety of different specialties, so can advanced care providers. They can be, many of you may have encountered this yourself. Not only do you have a primary care provider, but you may have a pulmonologist or an allergist or a rheumatologist or a neurologist. There's all kinds of specialties. And when you're caring for a patient, especially when they have multiple different advanced care providers on their case, the nurse can be really instrumental in making sure that all of those pieces are together and that the patient understands everything that's happening to them. And again, that kind of goes back to not only advocating, but educating about what is going on. So we're going to talk about something called QSEN, which stands for Quality and Safety of Education for Nurses, or something like that. And QSEN has 6 different competencies that we talk about, and you'll be able to learn more about these competencies by following that link that I provided for you in your module about managing care. And you should be following that link. That's where I got a lot of this information. Your book talks a little bit about QSEN. It really is interwoven throughout the various different concepts. But that online website is really going to be a great resource for you when you're learning about QSEN. And this is interwoven through the NCLEX. You'll see a lot of these words: patient-centered care, collaboration, evidence-based practice, quality improvement. You'll see all of the practice questions that you do, especially on things like ATI and other NCLEX products, how those questions map out to this quality and safety education for nurses competencies. So the purpose of QSEN is to prepare future nurses with the knowledge, the skills, and the attitudes necessary to improve the quality and safety of the healthcare systems in which they work. We always have really done this. This is not a concept. We're always looking at quality. We're always looking at safety. But here in the nursing programs, we want to make sure that we're including these competencies into your education, and so that's why you'll see these terms throughout the semester. So we're going to kind of dive a little bit deeper into each one of these different competencies, and you'll notice that some of them kind of overlap a little bit. They do have unique characteristics, but they will overlap a little as well. Patient-centered care, this is exactly what it sounds like. It's all about keeping the patients at the center. They are the source of control, and this can be really hard to lose that focus. As nurses and as other healthcare team members, sometimes we forget about the patient. So our focus is on treating each one of our patients with respect and dignity. We want to engage them in the decisions about their care, and we want to consider values and preferences and needs. And again, the nurse is really a driving force for this. We're spending that large amount of time at the bedside with the patient, providing education. We want to draw the patients out and help them to be able to communicate what it is that they want to happen in their care. Nurses have to be able to communicate well with patients and have a good understanding of what the plan of care is, so that they can provide the education needed for patients to be able to make the decisions that they want to make. Now, you will run into patients who have made decisions that you do not personally agree with, and that's okay. But as a nurse, you really need to understand that our job is to not be the judge of this person and their decision. They are coming from their own unique place and their own unique situation and their own unique culture and set of values, and we shouldn't be trying to impose our own culture and values and situations on to that person to persuade them to make a choice that we would make. Remember, this is patient-centered care, right? So we need to understand that everybody is okay to have different choices than maybe what we do. It can be really difficult sometimes when we're talking about some of those big buzzword type choices that we may not agree with, such as abortion or euthanasia, code statuses, different decisions that are made about DNR and healthcare power of attorneys and things like that. And so we have to be very careful as nurses that we're not imposing our will upon the patient. One reason why patient-centered care is not only important, but also helps to, I guess, improve the outcomes of the patient, is because if the patient is making the decision and if they're involved in the care, then they're more likely to be an active participant in their care instead of just a recipient of our care. So for example, if you have an individual who maybe has, I don't know, high blood pressure. I like to talk about high blood pressure. Let's just say they have high blood pressure. And one of the things that they need to do is take a medication every day. And you go to them and you say, you need to take this medication every day because your blood pressure is too high. And if it continues to be out of control, you're at risk for heart attack, stroke, coronary artery disease, all these horrible long-term effects of hypertension. And the patient says to you, well, I'm not really interested in taking medications. And you respond by saying, but you need to take this medication. It's what the doctor ordered. That's not providing patient-centered care. That's imposing upon the patient a decision that's being made by the healthcare team and making the patient do it. So eventually that patient might just be like, okay, fine, whatever, I'll take your medication. And then they go home and they don't take their medication because truly they were not really on board in the first place. So the way to approach that situation with patient-centered care would not be to just impose your will upon them or what the doctor's orders are, but to find out why the patient is actually taking that particular position. So you might ask the patient, what is it about taking this medication that makes you hesitant to take the medicine? And maybe it's because they heard something from a friend of theirs that took this medication and they died. Or maybe they're really into holistic and natural healing. Or maybe they just don't have the money to pay for the prescription. There's a variety of different scenarios that can occur. But as the nurse, we can help them figure out what would be the best source of action. So let's just say the patient was prescribed a diuretic called furosemide to help control their blood pressure. And they're telling you when you investigate that they don't really want to take that because they already have stress incontinence because they've had 6 kids, and they know that taking a water pill is just going to make them urinate more, and they're already embarrassed about having incontinent episodes and the impact that has on their daily life. So knowing that information, the nurse can then advocate for the patient and discuss with the provider, or encourage the patient to discuss with the provider, is there an alternate medication that can be prescribed? So just to give you a little personal example, sometimes it's just some education that can make the patient feel a little bit better about being compliant. My mom is I love her. She's very non-compliant medically though. And that's okay. She's like 71. She's earned the right, I suppose. But she exactly was taking a diuretic, and she wasn't wanting to take it because she was having, just as I described, issues with incontinence. She's had a bladder lift in her past, has had to have multiple bladder surgeries, and she has to get up and pee all the time, and so she doesn't sleep very well. And so one day, just as her daughter, she was telling me about these issues that she had, and I suggested to her something to help with that. And I said, Mom, why don't you, instead of waiting until you feel like you have to go to the bathroom, do what we in nursing like to call implementing a toileting schedule. So instead of peeing when you cough, or having to get up in the middle of the night, why don't you just go to the bathroom every 2 to 3 hours, sit on the toilet, and just pee and see what happens. See if that works, because maybe that can help you. And then I also said, don't take your medication after 5 p.m. so that way it has time to wear off. And additionally, try not to drink any fluids after like 6 or 7 if you're going to go to bed by 10. And so she actually did those things, which I was completely surprised by. And the last time I talked to her, she said she'd been sleeping really well because she had been doing what I suggested and just going to the bathroom every couple of hours. And she was getting the best sleep she had gotten in a long time because she wasn't having to get up to go pee in the middle of the night. So that's just a personal example of how really digging in and figuring out why a particular thing is not desirable for a patient can help you use your powers of education and knowledge to assist them in their health, and they're still in control of that situation. And you know what? If it hadn't worked, we probably could have talked about implementing something else. Okay, so attributes of patient-centered care. This is when we're looking at their values and their preferences, just like issues that my mother was having. We're coordinating care for our patients amongst all of the variety of different healthcare team members, making sure that they have access to care and transitioning their care. When a patient moves from like an acute care facility, such as the hospital, and are going to go home, do they have all of the follow-up care that they're going to need so that they aren't going to end up back in the hospital? Are we educating our patients and providing them with information for them to be able to make decisions? Are we taking care of their comfort and making sure that we're helping them manage their fears and their anxieties about whatever medical process that they're dealing with? And friends and family are really important. That's going to be the support system once they leave your care as the nurse. So when you're trying to figure out if you're looking at something that deals with patient-centered care, these are some of the attributes that you're going to recognize. Now, there are some special things that you need to consider within populations, different gender health considerations. You know, as much as I am for gender equality, there are really some actual differences in the way that we may need to approach care for men and for women. They're definitely going to have some potentially different types of health concerns. Other populations might be that we alter the way that we approach our care, might be veterans. You know, they might be dealing with things like post-traumatic stress disorder or exposure to certain toxins that left them in poor health, you know, different things like that. So again, this is all just part of patient-centered care and looking at that whole person and how you know, we can provide the best care to them. Culture and spiritual considerations can impact the way that people choose care. And so trying to understand the person and why it is that they make the decisions that they make, or why they don't do something, can be very helpful. Okay, let's look a little bit at care coordination. And again, this is part of patient-centered care. We're really trying to be that advocate for the patient and work with the rest of the team to make sure that the patient has everything they need to have good outcomes. I recently started working in the emergency department, and I'm really seeing a lot of good care coordination within that department. Did I say emergency department? I meant intensive care unit. Anyway, I'm really seeing a lot of good care coordination in the intensive care unit with the patient-centered rounds, and I'll talk about that in just a moment. But when we're coordinating care for our patient, we're working with those other team members to make sure that they have all the bits and pieces in place that they are going to need. There are some specific roles or jobs that nurses can have that also work with care coordination, such as case management or transition management positions. Now, not every facility will have a case manager and or a transition manager. But they might have. But really, again, what we're doing is making sure the patient's getting good quality care, that it's cost effective, that they have access to what they need, so that when they go out into their whatever world it is they're living in independently, or long-term care, or assisted living, or whatever, that they have those ongoing needs met. And that will kind of segue us here in just a moment into our next topic called teamwork and collaboration. But just to wrap up on care coordination and transition management, a lot of these things were brought on by the Joint Commission. And if you don't know what the Joint Commission is, this is a regulating body that ensures that hospitals are providing good quality, safe care that produces good outcomes. And they give us certain goals every year, or every couple of years, or whatever, to make sure that we're meeting them, the benchmarks. And these are some of the things that the Joint Commission has outlined for us to make sure that we have good care coordination and transition management. Things like providing discharge instructions that the patient can understand, making sure that they know how to take care of themselves. Again, more education, where to go for follow-up care. In some cases, we're even making those appointments for the individual so that they don't have to do that themselves. Making sure they have access to resources in their community. All of those kinds of things. Medication reconciliation. Do they know what they need to take when they're going home, and what medications perhaps they were on before that they are not on anymore? So on to teamwork and collaboration. This is our next QSEN competency. Nurses really need to be able to function within the teams. We need to be able to have open communication, mutual respect for each of the other team members, and shared decision making. And you'll notice here that the patient is at the center of all of this. Now, I realize my wheel here may have some repeats. I've just never gotten around to fixing that, but that's okay. And that there may be some team members missing, and that's okay too. Things are changing and being added all the time. But we're going to talk about some of these different team member roles. To work effectively within this team, you have to have an understanding of your own values and your own knowledge base, as well as your own limitations, so that you're able to reach out to the appropriate team member to help provide that holistic care for the patients. You also have to have an understanding of the roles of each of these individuals. You can't go to a dietitian and ask about medications. That's not inside their scope of practice. They're not going to know all of that information. That's not their specialty. Each one of the members in this wheel and the ones not included in this wheel are very important, and they're very valuable, and they all bring their own special something to the team for the patient. So let's talk about a couple of these team members. First of all, I want to talk about the nurse. Now, there are two different types of nurses listed up here, a registered nurse and a licensed practical nurse. And there are some of each of you within this program right now. The difference between a registered nurse and a licensed practical nurse has to do with the management of care. The registered nurse leads the care, develops the plan of care, and works collaboratively with the licensed practical nurse to carry out that care for the patient. The registered nurse is initiating care plans. They're initiating education, and the licensed practical nurse is reinforcing that initiation, whatever it is. So they work hand in hand. Some places will not have licensed practical nurses, and they will work purely with registered nursing. And some places will have primarily licensed practical nurses that work under perhaps a physician or one registered nurse within a facility. So there's lots of different models out there, but there are some differences in terms of what their role is. Regardless of those little nuances, the RN, the LPN are there at the bedside with the patient, providing that immediate care, and are most familiar with what's happening to that patient, how they're responding to treatment, the knowledge deficits that they have, the outlook that they have on the plan of care, the outlook they have on life, how they're feeling about things, what their assessment looks like. They're really right there in the nitty-gritty of everything. Close beside them is your patient care assistant, or sometimes a certified nursing assistant. They are different, but they are assisting the nurses. And they're providing a lot of that ADL type care that you guys are learning within your skills lab. Things like bathing and ambulating and they do so much stuff I can't even keep track. But they're there to assist the nurse. They're working under the direction of the nurse to provide care for the patients. Case managers typically are nurses, registered nurses primarily, I believe, and they're helping to coordinate all of the bits and pieces for when the patient moves on to the next facility, or even within the facility that they're in. So for example, if a patient is leaving the hospital and they're going to go to a long-term care facility, the case manager is going to help facilitate that movement by making sure that that there has been approvals, and that place will accept them, and that their insurance will cover it, and all of those little things that are going to make sure that the patient is going to be accepted where they're at. They might also arrange for home medical equipment for a patient. So if a patient's going home and maybe they need handrails or mobility devices at home, they can arrange for the patient to get those types of things. Social workers, those are typically not nurses. They have licensed clinical social work. They're really good for helping patients work through personal issues, emotional issues, psychological issues, drug abuse issues. They can work with them on that. What else do I see them do? They work a lot with providing education for power of attorney, healthcare representative. It's more of that social type aspect that they're working with. I do love social workers. They're good for coming and talking to the patient, helping them deal with things that's going on while they're in the hospital. Another person on the team that's really good about that is the chaplain. If ever a patient needs to just bare their heart and soul, we want to be there for our patient and provide holistic care, but sometimes, unfortunately, as nurses, we just don't have time. Pull in that resource that they can do that. A chaplain is really good at that. Physical therapy, occupational therapy, both of these disciplines work with mobility and movement of the patient. Physical therapy tends to work more with that gross motor movement, things like ambulation, transferring from bed to chair, that kind of thing. Whereas occupational therapy works more with fine motor activities of daily living. Oftentimes you'll see them working together and doing a lot of the same types of things, but they are two distinct disciplines. Our advanced practice providers would be our physician's assistants, our nurse practitioners, and our medical doctors. They're leading the medical care. They're diagnosing the patient with whatever disease process or that they're being admitted with or cared for. They're prescribing medications and therapies and diets, and they're doing all this stuff with a medical knowledge base. Pharmacists know just about everything about drugs and medications. If you ever have questions about medications, pharmacists are really brilliant. They know a lot about that kind of thing. See who else is on here. Dietitian, they come in and they look at patients' calories, whether they're getting their nutritional needs met. Perhaps they, need a supplement of some sort. Maybe they've lost some weight. They can work with you on dietary choices. I had a patient a couple of weeks ago who was refusing to eat anything, and her response to me was, "I can't swallow." So my first reaction was, well, maybe she's having some kind of functional issue with swallowing, and so I called a speech therapist and asked them to come see the patient. I had to okay that through the provider first and get an order, just to make sure that functionally they were safe for swallowing. And it turned out that it wasn't that the patient didn't have a functional issue. It was more of, she was a cancer patient, had been undergoing chemo and radiation, and had mucositis and esophagitis. And so her oral mucous membranes and her throat were really sore. And so I then worked with the dietitian to provide foods that would be conducive to that. Soft foods, cool foods, things like that, and was able to then work with the provider to get the correct medication ordered that would help with that esophagitis. So you see, just in that one little interaction, I pulled in 3 different disciplines to work for the better outcome of the patient. Let's see, who else is not on here? Respiratory therapists are fantastic. I don't know if every facility has a respiratory therapist. I think hospitals, when I say facilities, but they can help a lot with, oftentimes they will administer breathing treatments, like nebulized breathing treatments. Where I work, they manage the ventilators. They can help with intubation if a patient needs to be intubated. They help with some respiratory type procedures, so like with bronchoscopies, if they're done at the bedside, they're probably going to be present. Procedures where we're sedating, like doing a conscious sedation for a patient, they're going to be present because they're going to manage the airway. So their job is all about the airway and the lungs. So anytime there's an issue with that, we might consider consulting a respiratory therapist and seeing what they can do to kind of help us. Part of communication is being able to communicate succinctly and effectively, I guess, and that really plays well into your teamwork and collaboration. And so we talk about something called ISBAR, and that is an acronym that stands for identify yourself and your patient, state the situation, provide the background information, describe your assessment, share a recommended action, and then restate and document the response. The meat of ISBAR is actually SBAR, Situation, Background, Assessment, and Response. And this is a really good standardized way to communicate within that interdisciplinary team. There's actually an assignment that you have to do that you need to utilize SBAR to communicate about a patient in SBAR My Car. It's kind of a fun little thing. But I posted a video where I myself did an SBAR on my car so that you would have an example of what to talk about when you did your own SBAR. But it's just, I use this daily, and it takes practice to get into this routine of being able to organize this information in the correct way. Sometimes things overlap, especially your background and your assessment, but the situation is all about why, what's happening, what prompted this communication, what background does the patient have, is there significant history, are there things that have recently happened that are important to know in regards to this situation, what assessment did you find that prompted your communication and that supported the situation that you have, and what do you think should be done. It is okay to not know what to do. In fact, as new nurses, you might feel that way routinely, that you don't really know what you should recommend, and it's okay to say that. That's why it's a team. That's part of that, knowing your limitations. The more experience you have, the more you might kind of come to understand what a good recommendation would be. And that's okay too. It's just wherever you are in that stage of your career is going to kind of direct that. Sometimes you'll make a recommendation and it will get turned down. Be like, no, that's not really the direction that the provider wants to go. And that's okay too. At least you're collaborating with the healthcare team and throwing out ideas just to see what would be best for the patient. So don't be embarrassed if you make a bad suggestion. Sometimes you make a suggestion and you may have forgotten something that really is important. So for example, just this week I was caring for a patient who was having urinary output issues, and I suggested to the provider, maybe we need to give them some IV fluids because they're not really getting any IV fluids. And the provider was like, yeah, that's a good idea. But later, when I went to review the orders, he had actually discontinued IV fluids that had been ordered. I was asking him to increase the IV fluids, and he had discontinued them. And so when I reached out to the provider, I said, "Did you forget about our conversation, or is there something I didn't know?" And the response was, "Oh, the patient has a history of heart failure, and I think that their volume status is okay, and I don't want to overload them with fluids." Okay, fair. That was something that I failed to recognize. But it was a collaborative communication between myself and the provider, and both of our goals were the same, to meet the needs of the patient and support any deficits. But he just had a piece of information that I failed to look at. So don't be embarrassed. If you make a recommendation that doesn't get followed. We don't know everything. Another part of teamwork and collaboration is something called delegation, and this is where we're taking a piece of work and asking someone else to do that. Oftentimes this might be an unlicensed assistive personnel, or a tech or a CNA. That's what that would refer to. It could also be an RN delegating to an LPN, delegating to a CNA or a patient care tech. An RN can delegate to an RN, an LPN can delegate to an LPN. So really the key to remember is you need to make sure when delegating a task that it's being delegated to the appropriate person. For example, as an RN, I cannot ask my patient care tech to fix my IV fluids that are beeping in room 2 because it is outside their scope of practice to do so, because there is an assessment that needs to be done before that IV fluid can be restarted. As a patient care tech, I should not fix that IV fluid because it is outside my scope of practice to assess a patient. Okay, so you need to know the limitations of the person you're delegating something to. The other piece of that is remember that the nurse is still accountable for that task that has been delegated. So if I ask a patient care tech to go check vital signs on a patient, and they get busy doing something else, and it was never done, it's still my responsibility to make sure that that was done. There's, even though we're kind of giving that task away to someone else, we never truly give it away because we're always still have some sort of accountability for that. And part of that is supervision. Not everybody, when you delegate something to them, even if it is an appropriate delegatable, if that's a word, task, they may not know how to do it. And you might find this yourself in this situation as new nurses. You're going to require supervision. So you may be asked to place a Foley catheter, for example. As a new nurse, you've got your license and everything, but the only time you've ever placed a Foley catheter is in skills lab. And it would be completely appropriate to ask another nurse to go with you and help you. And it would be inappropriate for another nurse to say, "No, go do it yourself," because that is a task that requires supervision, because you haven't been able to prove that you have performed that competently, even if it's just within yourself. I hope that made sense a little bit. One thing that I always have to supervise quite frequently is administration of enemas. In Bloomington Hospital, our patient care techs have always been able to administer tap water enemas to patients independently. They're taught that in their tech training. But it doesn't happen all that often. Thank God. It's one of my least favorite things to do. So oftentimes I will delegate, "Hey, can you go give so-and-so a tap water enema?" And their response is, "I've never done that before." So now I've taken on the role of teaching that person how to do it. And so typically what I do is I just guide them through it, just like I would with you guys as a student in any other task. That way, the next time they're asked to do it, they will feel more comfortable doing it because they've done it before. Here are the 5 rights of delegation. We kind of really talked about this already. Right, tasks, circumstances, supervision, communication, person. So I'm not going to spend any more time on that. I've already kind of talked about it. Okay, evidence-based practice. Evidence-based practice is considered to be quote-unquote best practice. It's a problem-solving approach to healthcare delivery and nursing care. It's based on evidence from research, and it's considered to be high-quality care and is very cost-effective. So when we're looking for data and evidence, it's important to understand that you're getting your information from a valid and reliable source. So we're not looking for Wikipedia, right? We're looking for high levels of evidence. Things like systematic reviews or randomized controlled studies, things like that, where we're having actual evidence with experimental groups and data that's being pulled. And we're looking at all of that type of level of evidence to make sure that we're getting good care to our patients, not just doing what we do because it's how we've done things for 50 years. You'll be surprised. There's a lot about nursing that you'll see that we've just always done it this way, and we have to ask ourselves, but is this really the best way to do things? Evidence-based practice is really the driving force that changes our work at the bedside. It's very nurse-led, but patients are always kept at the center. We're still thinking about patient-centered care. Nurses might see a problem and then implement solutions on how to fix it. This is where a lot of our protocols come from, such as those that prevent central line infections and catheter infections and ventilator-associated pneumonia. We have different bundles that are out there that are based on research that tells us, when we look at the evidence, that when we do X, Y, and Z, the patient outcomes are better. And as with any research, whenever we're able to duplicate that process and get the same results, the evidence becomes stronger and stronger. Quality improvement can sometimes seem a little similar to evidence-based practice, but it is different. Quality improvement is an ongoing process where we're constantly striving to be better providers of care. We're constantly trying to produce better outcomes, to make processes better and more efficient. Sometimes these are just really small changes in the way that we do things. Even something as simple as a communication board to make sure that specific tasks are completed. I've seen that implemented on various different units, or trialing a new process of discharge. So you'll constantly see in healthcare things are changing because we're always trying to make our outcomes better. So quality improvement keywords there are ongoing and using data to make sure that our outcomes are what we want them to be. Safety really focuses on minimizing the risk of harm to the patient. I mean, we really do this in almost everything that we do when we're talking about patient care. We do it both at a system level as well as at a personal level. Safety is really the way that we practice. It's the standard processes that we follow, and it's why we have all of these other competencies that we've been talking about in place. So again, looking at what the Joint Commission, that accrediting body that we mentioned earlier, they recognize that patient care effectiveness, safety, and continuous process improvement are things that help improve the outcomes of our patients. So here are some of the safety goals that Joint Commission outlines for us on a routine basis. Things like making sure we have identified our patient properly. This is where barcode scanning came from, making sure that we have the right patient and that each patient has a unique barcode identifier. Same thing with medication administration in that scanning process. They've also asked us to monitor alarms and make sure that alarms are necessary so that nurses don't suffer from something called alarm fatigue. Infection prevention practices, why we place patients on certain types of isolation or certain types of hand hygiene when we're talking about transmission. So these are all examples of safety. The Joint Commission really encourages a blame-free approach when it comes to some type of error that does occur or breach that happens within safety. Some safety breaches are more serious. That might be a sentinel event. Let me see if I can think of one. If off the top of my head, I would say a fall that results in some kind of head injury. That would be a sentinel event. But the way that these are carried out would be through something called a root cause analysis. And that is what we're talking about when we're talking about a blame-free approach. Looking at everything that happened along the way to figure out where the system failed us, so that we can fix that and patch that failure within the system. So perhaps, oh goodness, I always have a good example for this, but right now my mind is not working on one. So for example, perhaps a patient requires a diluted heparin flush in a particular line. Okay, and in the medication dispensing machine, there are two different concentrations of heparin flush. One of them, of course, is more concentrated than the other, and perhaps they're both stocked in the same cabinet. Okay, and so when you utilize the medication dispensing machine, which is a good safety practice, and a door opens and you have access to like 4 different pockets, you reach in and you grab the one that you want. Okay, but it's not really the one you want. Maybe it was stocked in the wrong place. Who knows? There was some kind of breach there, and so you end up giving a higher concentration of a heparin flush to somebody, and they end up bleeding, right? Somewhere along the line, perhaps, then those two different concentrations of heparin flushes might be separated and placed into different locations. So that would be the result of like a root cause analysis, where we saw that there was an error that happened. Another root cause analysis that I recall happening was we used to use insulin pens, and insulin pens are patient specific. They can't be shared between patients. And there was an instance when there was somebody who had received insulin like they should have, but it was not from their pen. And so what came out of that was they ended up getting rid of insulin pens and went to insulin vials. So that's the whole concept behind the blame-free approach. We really are trying to figure out, did someone maliciously do something wrong, or was there some kind of problem in the system that can be fixed so we don't have the same error happening again. Healthcare informatics is the use of information and technology to communicate, manage knowledge, mitigate errors, support decision making. It really is the responsibility of the nurse to manage healthcare information responsibly. And with advancing technology and access to greater amounts of data and information sharing, we really have to be careful with informatics. We have to think about HIPAA. Who can we share information with? This has been particularly challenging for me as a nurse recently because of the lack of visitors that are allowed to come to the hospital. How do I know that you're the husband that's calling? I don't really. So that can be a little bit challenging sometimes. It is really good, though. It helps give real-time data. If I put in a blood pressure on my patient right now, someone on another computer on that same system can see that at that real time, and so they can make good decisions. So informatics definitely has made a lot of things more convenient, easier to find. You can look things up like immediately and research stuff, but there are also risks that are associated with it, and the potential for private information to get out. Okay, nursing vigilance. What nursing vigilance refers to is the state of watchful attention that we as nurses should always have. And what that means is everything that I assess, whether it's an observation or an objective assessment, or something the patient tells me is subjective assessment, I'm attaching meaning to that. And I'm always watching that piece of information to see if there are changes in it and attaching meaning to those changes. So for example, if I hear a patient's lungs in the morning, if I'm doing a lung assessment and I hear that they have some crackles in their posterior bases, and I educate the patient, take deep breaths and cough and let's get up and move and all these things I would normally educate a patient on that has crackles in their bases. And then later on, I recognize that their respiratory rate is elevated, their oxygen level is a little bit lower, and they still have those crackles, and maybe they have a little bit of a temperature. I'm thinking about what all of that means, right? It's requiring more effort for them to breathe. They're requiring more breaths to get the oxygen they need. Their oxygen level is still a little bit shoddy, and their lungs aren't oxygenating while they don't have that space for perfusion because of all of that fluid in there that I'm hearing, right? So that's what we really mean by nursing vigilance. And some things can be very subtle. Sometimes it's the nurse just has a feeling. They may not necessarily be able to quantify exactly what is happening that is different, but something is not right. So part of that whole state of watchful attention, that vigilant attitude, is being ready to act, whether that's to intervene appropriately within your scope of practice, or call a provider and say something is happening here, we need to do something about this, or to work with them about identifying what the actual problem is. So again, here we're attaching meaning about what is actually happening, what you're seeing, what you're observing, thinking about the different problems that might be causing that, or that might arise because of that, calculating the risk of our actions, being ready to act so that we can avoid harm to the patient. And then on a continual basis, we're monitoring how effective or ineffective our interventions were when we actually did act. This is really kind of similar to the actual nursing process. Failure to rescue refers to the inability to save a patient's life when the patient is experiencing a life-threatening event. It can be because of a multitude of different reasons. You see 4 of them listed here. I would like to provide you with an example. So I used to work on a medical surgical unit in the hospital. I worked primarily weekends, which are notoriously known for lower staffing. I also was the charge nurse on the weekend shift exclusively. I was the primary charge nurse. And there was one weekend when I came in and I was working, and we didn't have a unit secretary. Unit secretary or unit coordinator is an imperative part of the team. They're at the desk, they man the phones, they help make sure that patients get beds and let us know when beds are available, and can field questions, and they're like the command center of the unit. On this particular day, I didn't have a unit secretary. I was also short a patient care tech. I needed 2 and I had 1. And so I was assisting the patient care tech that we had with, answering call lights and helping patients to the bathroom and doing baths. And I was also short a nurse. Ideally, the charge nurse doesn't take patients, but on this particular day, I did have to take patients, and so I had this patient load I was caring for. So already I had staffing issues. And I was fulfilling not only the primary nurse role, but the charge nurse role, patient care tech role, and a unit secretary role. So on this particular day in question, I was at the desk, I was answering phones, it was really kind of busy, and I received a phone call from the telemetry nurse. Now, telemetry is what we refer to as like the people who are on heart monitors. They're all getting watched in like this room on another floor. That's our telemetry nurse. And they called and they said, your patient in such and such room, I'm noticing this change on their cardiac rhythm. How are they doing? And my response was, I'll go check on them, and I'll let you know if anything's amiss. Well, in fact, I didn't go check on them because when I got off the phone with them, I had other phone calls. A provider came to the desk, was asking me a bunch of questions. I'm answering call lights. And truthfully, I just forgot to go check on them. A time later, that telemetry nurse that had called me came walking through the door, and she said, hey, did you ever check on that patient? Because I'm still noticing something's not right on their heart rhythm. And I go, oh, shoot. I got busy and I forgot. And she was walking down to the room, and so I was like, well, now I have to go check on them, right? Because I got to do what I'm supposed to do. So I went to check on them, and my patient was laying passed out on the floor in the bathroom. Pause for effect, right? That would have been a example of failure to rescue. Now, this patient, it turns out, had a hypoglycemic episode. Their blood sugar was like 20 or 40 or something. It was low enough for them to pass out on the floor of the bathroom. And we gave them some dextrose, and they were okay. We did send them off the unit to monitor them for a while. But that was an example of a failure to rescue, not only due to staffing issues, but also due to task orientation. So there were a couple of different things playing in there. Levels of licensure and levels of experience can also impact failure to rescue. If you have a whole shift that has brand new baby nurses on it, you're more likely to have some type of problem like that occur, just because you don't know any better. You don't have that type of experience to be able to make those judgment calls that a more experienced nurse has had. So we have to be able to use clinical judgment, and these are the processes that we use to make decisions based on that interpretation of the patient's needs or problems. It involves the nursing process, it involves critical thinking and reasoning, and this is how we circumvent failure to rescue and how we implement vigilance through this model of clinical judgment. Now, in your book, the author uses some different wording than what we traditionally think of when we talk about the nursing process. So I just want to point that out so you have a reference from which to go off of your book. So the first step of the nursing process is always assessment, and that's where we are gathering our data. And your book refers to this as noticing, okay? The second step of the nursing process would be diagnosis or analysis, right? We're interpreting that data. We have our assessment, we have our data. Now we're going to interpret it into a problem or a diagnosis, okay? And so your book terms that interpreting. The next step is planning. Okay, planning and implementation. Those are actually the next two steps of the nursing process. And your book refers to that as responding. In other words, we're making goals and we're carrying out our plan. And then finally, we're evaluating. In your book, that's termed reflecting. Did this work? Did it not work? Do I need to make adjustments? What's happening here? So we notice things that are happening. We interpret those things. We respond to those things. And then we evaluate, did it work? Did it not work? What do you think? Okay, so I just wanted to kind of put that final little thought in there about the nursing process and how your book lays out the nursing process. So I think that's it. I feel like this was a pretty lengthy lecture. We don't have a specific test on managing care. This is just kind of some introductory type of concepts. You do have some assignments that you'll need to do, but that will be the evaluation of your knowledge and understanding of these concepts is through those assignments, but I won't be specifically testing you on this content. Please, as always, let me know if you have any questions or if there's something that wasn't quite clear to you. Don't ever hesitate to reach out.